I'd like to introduce our next speaker. He is the head of Office of National Coordinator, or ONC. Like many of us, Dr. Micky Tripathi was very passionate about changing healthcare, and to see someone lead ONC is something I think the government has made a really wise choice. So, Micky, we're going to go ahead and give an update from ONC here next.
Morning. Really glad to be here. This is the group that I always, and I was joking with some of my HHS colleagues, that this is one of the groups that you always have to be prepared because you're the PhDs. So it's like, oh, the Q&A is really detailed with this group. So definitely look forward to the discussion. And what I thought I would do is also, because all of you are very well versed in all of this, I am going to do a very fast, broad sweep of kind of all the things that we're doing right now at ONC, to give all of you just a sense of it. Again, because I think for most of the vast majority of you, I think, if not all of you, you don't need the details of the basic fundamentals of who is ONC and what do we do and what is certification and all of that. But focus much more on all the different things that we're covering, and then happy to really have a little bit more engaged discussion in the areas that you're really interested in during the Q&A, and hopefully I can get through all of that. So. Seatbelts buckled. Here we go. So I like to focus ONC's activities in a couple of different ways. One, of course, on the right-hand side is all the rules, right? HTI 1, HTI 2, appropriate disincentives, blah, blah, blah. All of us know those vehicles. But I also like to do a little bit of the left-hand side, which is what is it we're trying to accomplish? Like, how do we actually think of this in a narrative that, that makes sense from a healthcare perspective? And I break it out into, these four different categories. One is, continuing to build the digital foundation. We spent $35, $40 billion in federal dollars, as well as an equal amount probably on the private side, and then at least an equal amount in the blood, sweat, and tears of people implementing electronic health records. But now we've got this digital foundation, which is pretty fabulous if you think about it. It's a relatively short period of time, and now 97% of hospitals and almost 80% of ambulatory practices across the country have not just any old electronic health record system, but a certified electronic health record system, which is not perfect by any means, but I think all of us will hopefully agree that is a pretty substantial capability that you can kind of count on, across the country. And it's now the opportunity to start building on top of that, which is what we, spent all that money and all that time and all that effort, to do. So, but we want to continue to build that digital foundation. So we've done a tremendous amount of work. We're now able to stand on top of that and say, what is it we want to do? But we still need to keep moving forward with data standards to have that, as much standardization of data as we can get, but we need to do that in a judicious, thoughtful way, working with all of you in the standards development community to be able to move that forward. We also need to keep focusing on the health IT gaps, because there are many parts of the care continuum that did not get the benefit of those dollars, I think, as all of us know. So we're spending time in the department looking at behavioral health IT, for example, and the secretary has asked us to lead a strategy across the department on behavioral health IT, adoption and support, recognizing that, on the one hand, we do, and we have repeatedly asked the Congress for more funding for funding for what might be like a meaningful use sort of program. But in the absence of that, we're just saying within the department, we have levers that we can pull. So, and that's, we're doing work on trying to align the different funding streams that come out of the different agencies to say, how do you get just, better bang for the buck if we work more together across our agencies to be able to make more dollars available for those in the behavioral health community, for example. LTPAC is a similar kind of thing that we're starting to work on. The second is making interoperability easy. So you build that digital foundation, you provide tools or make tools available. How do you get them to connect more easily than they do today? Lower that activation energy so that people just find it easier than faxing. Because if faxing is easier, people are going to fax, right? And everyone understands that. So you have to make it easier than that. And so, I'll talk about TEFCA, I'll talk about APIs as, sort of key strategies and priorities that we have there. You also end up, it turns out, you also have to promote information sharing. You can't just provide the tools. 21st Century Cures Act was, the congressional statement that we have provided a whole bunch of tools to a whole bunch of people, and we're still not getting the sharing that we want. Clearly, we need to do something in the way of a little bit of kick in the seat of the pants. And that was the information blocking provisions that came out of the 21st Century Cures Act. But they also did call for TEFCA. They also called for Fire API. So they were working on the how do you make it easier, but also how do you encourage people to actually do it. The other thing is we've got a health IT alignment policy within the Department of Health and Human Services that aligns the different agencies. I'll talk about that in a second. And then finally, ensuring responsible use of digital information. So you've got, provide the tools, make it easier for them to connect, encourage people to use the tools, but how do you know that the information that's now flowing is being used responsibly? Is there anything we want to do with respect to guardrails there? We're doing a bunch in health equity. I'll spend a little bit more time on AI because this wouldn't be a meeting if we didn't discuss AI, right? I think it's a department requirement right now that at every meeting we discuss AI in some way, shape, or form. So I'll touch on that as well. Just on the right-hand side, again, because all of you are deep in the weeds of this, I'll just touch on the various rules that we've got going on. And for those of you who have tracked ONC, we are like at an unprecedented level of intensity right now. Typically, ONC does like one rule every 3-4 years. We have 3 rules that we're pushing through simultaneously, plus TEFCA, which is probably 2 rules in and of itself. So we've got a lot of stuff going on. So if the ONC staff seems particularly frazzled, in a good way, I think all of us are really excited about sort of the leadership opportunity that the secretary and the deputy secretary have given us and the administration generally to do a whole bunch of stuff. So everyone gets motivated when you feel like you have impact, right? And I think that's certainly true for the ONC team. That yes, it's really hard work. Yes, we're doing a whole bunch of stuff all at the same time, but we feel like we're having impact, and that's always very very gratifying, I think. So we've got I'll talk about the HHS Health IT Alignment Policy, which is a little bit more of a department policy, but I think it's important for all of you to be aware of. We have HTI 1. Which is our draft rule that's out right now that covers certification as well as some other aspects like AI. We've got a draft rule, HTI 2, that we're trying to get out before the end of the calendar year as well. I think the unified agenda says November. Not sure we're going to hit November, but hopefully we'll be able to get it out before the end of this calendar year. So yes, we will have a rule that we are finalizing, and then the draft rule following for the next one, following right after that. TEFCA. Go live being planned in mid-December, so we'll have more details on that, but we are very lined up to be able to do that. I know Mary Ann Yeager is going to be speaking tomorrow. We have a number of QHINs who are ready to go. There are actually a number of QHINs who were pushing us in September to say, why can't we go live now? We're ready. And then we were the ones who were slowing them down and saying, all right, time out, hold on. We have a whole bunch of other stuff that we need to put together. But we're really excited about that. So we'll have a number of QHINs that are ready to go, and we'll go live in 2023 with the basic, classic version of TEFCA, which is IHE-based exchange, which is the bridge from the existing ways that, interoperability is happening at scale. But we've got the fast follow of FHIR, and that was one of the things that we added in coming in this administration was to explicitly say FHIR has to be a part of TEFCA-based exchange, and we're working hard on having FHIR exchange go live in TEFCA in 2024. I'll talk about some of those details. And then there are a few other rules from our agency partners that are really important just to keep track of. One, we did release, I guess it was, maybe it was last week, the appropriate disincentives rule. I'll talk about that in greater detail related to information blocking. And then CMS has a really important draft rule that hopefully all of you are following. I know a number of you do follow CMS really closely. That interoperability draft rule, I think, is really groundbreaking in many ways, and we're really excited to be partnering with CMS on that. And it helps to sort of complement very complementary kinds of things we're trying to do there that I hope can be things that allow the market to be able to move forward with the added energy that the market can that only the market can bring to bear. And then of course I think the last rule that you're familiar with is that information blocking enforcement is now in effect as of September 1st. The Office of Inspector General finalized that and in July I think. And then they have said that investigations start in September 1st. We're appropriate. So a whole bunch of stuff going on, and I know that all of you know all the details of that, and there will be a quiz at the end. So let me just talk now. I'll dive into detail into some of these various topics. The one thing that you may not be as familiar with, but I do like to point it out because you should hopefully start to see the benefits of this over the next couple of years, is Secretary Becerra and Deputy Secretary Palm put into place a policy across the department that all agencies in the department are required to support ONC standards in all of their regulations, all of their policies, and all of their funding. That's contracts, grants, any of their funding, anything that comes out of the department has to be based on ONC approved standards where those are appropriate. And the reason for doing that is because we've got what we wanted, which is many federal agencies wanting to do things with electronic health records. And that wasn't a big deal 7 years ago because we just didn't have broad adoption across the industry, and so a lot of agencies weren't really doing a whole lot. But now almost every agency in the department has plans or is actually doing stuff, from research to provider organizations and to public health, to everything CMS does. And we're starting to see more entropy starting to take place, where people are starting to do their own thing, their own custom standards. And we believe really strongly that we as the department should be putting our money where our mouth is. Which is to say that we should be modeling the behavior that we're asking the industry to model, which is using standards, using standard interoperability mechanisms, using data standards where they apply, so that all of you are feeling, not fragmented across, different agency partners, and that we can get more bang for the buck on behalf of the tax holders. Because that allows us to sort of say we're acting more efficiently in the department using these standards and that helps our purchasing power multiply the effect of our regulatory power as well. So you should start seeing more and more of that coming into play. ONC is providing technical assistance to our agency partners so that they can come into alignment with this. And we've already identified something like $1.5 to $2 billion of health IT programs across HHS. And that's just in a first sweep. And those are all programs that we're providing technical assistance now to help to sort of align them with things like the US CDI, FHIR APIs, things like that. So you're familiar with US CDI. I'm not going to bore you with that. We do have a number of things that we're doing with the US CDI. And I think as you probably know, we have proposed that the US CDI version 3 be the certification standard, the standard that's required to be supported by certified electronic health record vendors in our draft rule, HTI 1. So we're getting a lot of feedback on that, but if you look at the public comments, and I think the public comments have been pretty positive, actually, about moving forward with that. It's really important from a health equity perspective, for example, because it has a number of health equity data elements that we added actually in the summer of 2021, but with regulatory cycles, this would now instantiate this as a requirement that needs to be supported. This will have multiplicative effects across the department as well, because we've got many of our agency partners who are very eager to incorporate more health equity focused kinds of programmatic dimensions in their different programs, whether it's CMS and under CMS, the ACOs, CMMI, as well as CDC and public health, HRSA, all of them are waiting for and hoping for the ability to have more standardized approaches to this. So there's going to be I think not just with what we're able to do with with ONC and CMS levers related to certified electronic health record technology, but it will, I think, start to ripple out to to affect and benefit other programs as well. We also have a number of initiatives that stem from that we've launched that we call USCDI Plus, and that is to try to balance the sort of the very methodical annual approach that we have for taking industry feedback, taking agency input into what should we add to the US CDI. And we do that in we try to be very thoughtful about it and pretty judicious for things that, would apply across the industry, because the US CDI is, as I said, it's 97% of hospitals, 80% of ambulatory providers. So anything we add, every single data element, we do have to ask ourselves the question, is this something that's really generally applicable, that in any arbitrary situation, someone would say, yeah, that data element actually generally makes sense, to add that to that minimum data set. But there's a lot of energy among our agency partners for additional data elements to support their particular programs. And that's why we created the US CDI Plus program, to be able to meet that need and to channel that energy in ways that ties it to the US CDI, so at least we're all starting from the same place. Don't reinvent how you represent medications. Don't reinvent how you represent demographics. And then extends from that to be able to support their individual agency programmatic needs. And that allows the opportunity for, for them to say, well, for those who are participating in our particular programs, they can in the future say, you're also required to support this US CDI plus data set, but it doesn't apply to everyone. It's only for those who choose to participate in those programs, and we can work that into voluntary certification and all of that. So we've got very active work going on with CMS on a US CDI Plus for quality roadmap that helps support their quality roadmap with DQMs and ECQMs, all of that for those who are following that. We also have very active work going on with the CDC and jurisdictions on US CDI Plus for public health, so that we can have a nationwide public health data model. And we are just about to launch, HRSA has already launched the UDS Plus, which is Federally Qualified Health Center reporting, which is basically a US CDI Plus for UDS reporting. So that work is actually in production, and the exciting thing about that is it's also moving it to FHIR-based reporting. So we worked with HRSA to stand up a FHIR server so that they can actually receive those results, the updated data sets via FHIR resources rather than the ways they're doing it today. So that's a pretty exciting development, and HRSA has actually leapt out ahead to sort of say, we're not only going to do the new data elements, but we're also going to do it in a FHIR-based way, and we've got a number of vendors who are actually already piloting it. And then finally, we are just about to launch a US CDI Plus for cancer, working with the National Cancer Institute, the Cancer Moonshot team from the White House, FDA, CDC, to start to look at what are the additional data elements to support all the various cancer initiatives, which I think, as you know, is one of the president's top priorities. And so we're working really hard to be able to directly support that. So a bunch more will probably be in the works, but this is enough for us now, and so we're just moving ahead with this to try to tap that energy. Let me talk a little bit about FHIR APIs. FHIR APIs, I think, as all of you know what FHIR APIs are. I don't need to describe that. But just as a reminder, the requirement in ONC regulations was that by the end of last calendar year, so by December 31st, 2022, all certified EHR vendors were required to make available to their customers a standard FHIR API supporting the US CDI. So that was a requirement that they make it available to their customers, not just that they get certified. So at this point, and then CMS, working as our partner, came in and said in their payment rules that as of October 1st of this year, all providers participating in certain payment programs were required to have that version of the certified technology in place. So you have both of us working together there to say, now we want to be able to sort of firmly establish that we have got a foundation of standard APIs for access to the US CDI across the country, standard FHIR APIs across the country. So I think it's a real threshold moment, and over the next year or two, I think we should start to see people actually starting to build on that now that they're familiar with that. I mean, I often speak to investors and VC community, and so many of them are not aware of that. And you sort of think about all those small developers who are trying to do stuff, being able to make them aware that we did this for you. This is why we did this. So now it's available, and you ought to be pushing and banging the doors on those organizations that that are now required to have that FHIR API. And with information blocking, they're required to make it available as appropriate and as allowed by federal and state law. So real important moment there. And the requirement is for individual and bulk FHIR. Bulk FHIR is a little bit more challenging, but that is the requirement, and we'll want the industry to mature as we start to get around, wrap our heads around those use cases. One of the things that is sort of a little bit challenging about that requirement that that vendors make it available to their customers is that we don't know if they actually did. Right? I mean, it's very hard for us to track that. We can track what they certified to, and the vast majority of them did actually certify their API. So we know that they have the certified APIs, but did they actually make it available to their customers? So we're doing a couple of other things to try to do that. One is Inferno, which is our testing infrastructure that's used for testing of certain requirements for certification. But we are, on an ongoing basis, we add test kits to it to allow industry to hopefully use it as a way of supporting their local or their business initiatives, to be able to say, well, if you're going to, if we're all going to agree that we're going to do this according to a set of standards, here's an open source free testing tool that you can use, so all of us should just test against this, right? It's an open industry standard. If we're going to agree on a standard, at least you have a testing infrastructure that will give you a report on who's aligned and who's not. The hope is that that helps the market itself, take self-initiative and move forward. And that's all open source. We're going to continue to add more and more test kits to that, and so that'll be an ongoing thing. It's available to everyone, as I said, and it is open source. The other open source program that we have is Lantern, where Lantern does essentially a search for any APIs that are out there, any fire APIs that are out there, and certainly it's the EHR ones right now because we know where those are because they were required to publish their APIs on the ONC website, on the chapel, and then we go out and hit them on an ongoing basis. We're just continually hitting those APIs to see which ones are actually available, which ones are actually live, and what services do they support? Because Fire does have a services resource that tells you what does this Fire API actually support, and then we report that on Lantern. So you can go to Lantern, look it up on the ONC website, and it gives. And this is a horrible user interface. I actually have a meeting this afternoon with the Lantern team to say, what are we doing about this? Like this thing, like the tool is awesome, but that thing is not awesome. But you can go on there and you can see by vendor. You can go to Epic, Cerner. It'll tell you exactly how many endpoints they have. You can drill down and get to, oh, that provider has this Fire API, and here are the services that it's supporting. And for those who are payers in the room, we are coming after you too, because CMS requires, for the member-facing API, which we know has been let's just say, very spottily implemented across the industry, and there isn't a whole lot of enforcement. On the CMS side, they didn't require publishing of those APIs anywhere, like ONC does require that, as I said, on the ONC website, but we're going to go and just find them. So we're working with Karen, we'll work with others to sort of say, how are we going to find those APIs, and then we're going to publish them. And as the CMS interoperability rule kicks in with the other APIs, we'll start following that as well as a way of just providing information to the market about who's lined up with the regulations, and more important than who's following the regulations. To me, it's who is actually contributing to the open open architecture, open standards-based interoperability ecosystem that all of us are trying to create, and that's what this will give us some visibility into. So please use it. Please look at it. As I said, I promise we'll have a better interface, so it'll make it more attractive for you to come and use. That also is open source, by the way. So you can download your own version. You can tweak it. You can use it for your own local purposes. We're trying to work really hard to make all of this open source so that people can pick it up and use it, or just come to our dashboard and just look at what we're doing if you don't want to do that work. I do like to also always point out that we've got a number of Fire initiatives across the federal agencies that are helping to move us forward in the spirit of what I was talking about before. We require it in regulation, but then we're also saying, well, we want to use those regulatory levers, but we also want to use Fire in our own activities where that makes sense. And that's a growing sort of constellation now of Fire APIs. It starts on the bottom with the ONC requirement for the Fire API that I described that's now required to be in place. But then you have CMS picking that up, that technical specification up, and saying, well, providers, if you're in these payment programs, you're actually required to make that available. And then on the next one where it says CMS APIs, then they deploy the BCDA and the DPC Fire endpoints according to the same basic technical specification, and say, for our data, we're actually going to make that available via Fire API to encourage everyone to do Fire-based transactions. And then in the draft rule, with the payer APIs, they're now saying to regulated payers, you're required to have a member-facing API, you're required to have a provider access API, which for me, that is like the most exciting of all of these developments, is that provider access API, which says that every regulated payer has to make available an API like the DPC API, which is to say all fee-for-service claims should be available for a provider to be able to get access to. So that providers can get that perspective on care continuity, care management, see where their patients have gone that they don't have visibility into, and give them a better ability to go chase that information to be able to provide better care to individuals. It's shocking to me that that information is not available now, but this will start to instantiate. I'm assuming that it gets finalized, right? I always have to make that caveat. It's a draft rule right now, so we love what CMS is doing here, and we're strongly supportive of it. And then on the right-hand side, I already talked about HRSA on the left-hand side, and then on the right-hand side, we're working with the CDC to say, how do we start to think about the next set of use cases that can be Fire-enabled, like situational awareness, for example, so that we're not filling out spreadsheets and putting them into, what was teletracking, now it'll be whatever it is. And then also for bulk Fire access to immunization registries, which we know was a huge issue during the pandemic. And we want to be able to just say, why can't we have a single bulk Fire specification to be able to get immunization information from any IAS across the country using that same standard, as authorized, right? It's not for anyone, but as authorized to just be able to use that via Fire transaction. And then on top, I'll come back to this, you need some kind of network services to make these APIs scalable. Fire APIs are great And we obviously strongly support them, both in my personal life as well as in this position. But it's really hard to scale FHIR APIs on their own. Just because of the fragmented nature of the industry, you're always having to figure out where are those endpoints. If they're not published, I'm going to have to go and figure out where they are, and then I have to do contracting, and then I have to do onboarding, and I have to do a security handshake, and I have to go through all of this rigmarole. If I had a set of trust services on top that allowed me to just know that the other party has signed the same agreement, I have an ability to find those endpoints in a nationwide electronic directory. I have security already in place, so I don't have to go through this big, handshake kind of conversation. And I know they've been onboarded appropriately, and I know what rules of the road they're following. Then I could just fire off my APIs to anyone who's in that directory. That sounds a lot like TEFCA. Everything I just described. So that's why we're pushing really hard to say TEFCA trust services need to support FHIR APIs, because FHIR APIs are going to have a very difficult time. We're going to have a very difficult time scaling FHIR APIs without those kinds of trust services. So let's talk about TEFCA. We are, and how am I doing on time? Okay. So TEFCA, 21st Century Cures Act, directed ONC to do something here, network-to-network interoperability. The quick analogy I always like to use is like cell phones. You've got AT&T, T-Mobile, Verizon, all of them well-functioning, mostly, private cell phone networks. But on the back end, they're actually connected. So our user experience is as a single network, even though they are absolutely not a single network. They are different networks that are connected. And each of them actually has their own features and functions, right, within the networks. Most of us don't appreciate that. But there's things that you can do within Verizon that you can't do with other Verizon users that you can't do with AT&T users. Right? And the same thing in AT&T. But that's okay, because we've basically just agreed that there are a whole bunch of things that everyone should be able to do with each other. We should be able to call each other. We'll be able to text. We'll be able to do these kinds of things. And so that was basically the direction that the Congress gave to ONC in the 21st Century Cures Act, is that's the experience we need to have in clinical interoperability, because we've got a lot of networks out there, state and local networks, got a number of nationwide networks, and we want to be able to have the user experience of saying, I'm just going to join a network, and I'm not going to have to worry then about, am I connected to everyone else, which is the frustrating experience right now. Now, often you have to say, well, I have to join this nationwide network and this nationwide network and this local HIE if I'm going to have the coverage with, the connections with all of the organizations that I need to, that I share patients with. So that was, sort of the direction. So we're pushing really hard. As I said, we at the beginning of this year, we announced 6. There are now 7 qualified QHINs. Those are QHINs candidates who have been approved from an eligibility perspective. They have met the eligibility requirements to implement. And in February, we gave them the green light to implement. All of them are committed to going live this year. A number of them will make that commitment. Some of them have vendor changes and all of that, which is all the stuff that all of us know happens in IT. But a number of them are ready to go, and they will be going live, as I said, that before the end of the calendar year. We'll have more to come on that, but it'll be mid-December. So keep an eye out for a further announcement there. These are the exchange purposes that are allowed. We have what we call exchange purpose number 7, which is research. We intentionally didn't include that in the first ones because all of this can kind of live on HIPAA TPO. With research, I think, as all of you appreciate, you start to get into a whole bunch more complexity around de-identification of data, informed consent, all of that. And so that's why we deliberately sort of said, well, let's not have that out of the starting gate, because there's a lot of work to do to figure out how we would actually network enable that. But we've got a lot of appetite from our federal agency partners like NIH and FDA, who right now go through a whole bunch of heroic stuff to get the kind of network capability that TEFCA offers, and to be able to say, all right, how do we build those use cases to firmly establish research as a future use case? As I said, we are really excited before the end of this calendar year, go live with IHE-based exchange and then FHIR-based exchange in 2024. We're working right now on what we call the Common Agreement version 2, which is the version, right now it'll be Common Agreement version 1.1, which is what they're going to sign before the end of the calendar year. And then version 2 introduces FHIR-based exchange. And the reason that we have to have a new common agreement for that is because we're breaking open a little bit the sort of the pattern or the sort of the architecture of TEFCA-based exchange to allow FHIR APIs, holders of FHIR APIs, to be able to communicate with each other directly without having that brokered through a QHIN. As many of you may know, the basic architecture of TEFCA, which is kind of what we inherited from the work that was done prior to this administration, was a brokered exchange kind of thing. That every single transaction, you have a number of networks, but every single transaction would essentially go up to the QHIN. One QHIN sends it to the other QHIN, and then down, just like the cell phone network works today. That it kind of goes up to the Verizon network, Verizon sends it over to AT&T, and then back down to the AT&T network, right? That was kind of the pattern here. But as we look at FHIR, and as we look at the ways that FHIR has actually been implemented out in the market, it's very much a bottom-up phenomenon of people having their individual FHIR APIs and wanting to be able to exercise those. And so that's why I want to be able to support what we call non-brokered exchange, and to open up the ability for a participant in one QHIN to be able to just have a FHIR API exchange directly with a participant in another QHIN, just using the network services. So just being able to say, I am a payer, I want to be able to get information from 1,000 providers. What are their electronic addresses? Well, I can look that up in the TEFCA, in the TEFCA electronic directory. And then, do I know that they are participants? Well, yes, I know they have an electronic directory. That means they've got a cert. That means they've signed the common agreement. I don't have to worry about onboarding, and now I can just fire off my APIs directly to those other parties. And that goes both ways. Providers, payers, individual access is another very important use case. So the part of the reason that we're pushing really hard for FHIR is, in general, we believe very strongly that FHIR APIs are, as I said, are not going to scale, that FHIR actually needs TEFCA pretty desperately. But also there are some use cases that absolutely require FHIR exchange in order for them to, get the kind of adoption that we want to be able to see. One is individual access. Individual access has been, sort of a use case that HIEs and nationwide networks have been chasing for years and years and years, and have never accomplished it in the ways that any of us as patients would find satisfying. They do allow an individual, so Commonwealth does allow an individual using, an authorized vendor like a OneRecord or any of those ones that are out there, which are all great, and this is not a criticism of them. But what they find is that most providers actually won't respond to a request from one of those. And the reason they don't respond is because in the IHE-based framework, which is kind of a B2B pattern, there is no ability to really support in an end-to-end way the kind of compliance requirements that people want to have to be able to support their compliance needs, to have the assuredness that you need from the HIPAA privacy rule and the HIPAA security rule, for using what's essentially a B2B type of architecture to support a B2C use case. And that's a struggle that we've had. That's a struggle that all the existing networks have had, as they're trying to force fit that into IHE, and it doesn't work. And so we believe very strongly that that's one of the reasons that we need FHIR-based exchange to be able to support the FHIR OAuth pattern, where all the participants, who we've talked to have said, we will absolutely respond, and we're happy to have you put in to TEFCA as a required response to an individual request, as long as it comes via FHIR OAuth, because that allows us to have that assurance, that end-to-end assurance as they do today. So that's one very important use case for the scalability of individual access. The others is payers. As I think many of you may know, payers have been, kind of shut out of existing networks by and large. I mean, some of them are allowed to participate, but they also find the same thing, is that a lot of providers don't respond to them. And a part of that is because there is an asymmetry in the flow of information, that there's a lot of flow. In theory, there'd be a lot of flow of information from the provider to the payer, but very little from the payer to the provider. And so providers, understandably, I would argue, feel like this is a one-way street. There's talk of it being bidirectional, but they have nothing to offer me, or they're not willing to offer me anything that's of value to me, which would be claims, right? What do payers have? They have claims. And so the CMS interoperability rule has that provider access API that I was talking about before. So what we're working on with the providers and payers is to say that we can start off in a model that providers would basically have the option of not responding in an IHE-based world, as it happens today. It still allows you the opportunity to use that IHE framework to be able to do the exchange for those who are willing to do that. But once we get to the point that we have FHIR enabled, that payers who choose to make available a provider access API according to the CMS interoperability draft rule, we will then say that as it relates to TEFCA, then a provider is required to respond to them per request, which is a basic construct of network interoperability, your duty to respond to anyone else on the network. And then payers, in turn, would be required to respond to a provider request for all of their claims information. And that gives us the reciprocity, the business reciprocity that allows us to break through the logjam that we have in industry today. So we're working really hard to enable that. And again, another reason why we're pushing very hard for FHIR, because we believe really strongly that payer types of exchange needs to be a part of network interoperability, and it hasn't been up until now. Public health, of course, is the other one. I don't have a slide on it, but we're working very hard with the CDC to have some public health use cases so that jurisdictions can directly participate in network interoperability in a way that they haven't been able to in the past. Even during the pandemic, they weren't able to in the ways that, that we need them to. So let me talk, I'm just looking at the clock. Let me talk a little bit about information blocking, and then I'll just touch on AI, and then I'm gonna stop. So information blocking, all of you are familiar with this. In general, the only thing I'll say, and I won't spend a lot of time on sort of the foundation, because I think all of you are available, or all of you are aware of this. But just to point out that with the draft regulation that we put into place, which is the department regulation, even though it's listed as an ONC regulation, it's actually a department regulation. The Secretary's office asked us to just be the lead, but it is a multi-agency, it's a department level regulation that has a number of agencies. If you look at the draft rule, you'll see there's a number of agencies there, including ONC, CMS, OIG, OCR, the Department of Appeals Board. There's a number of agencies that are, that are all participating in that. And that, sort of at least fills out an important but part of the puzzle. So the puzzle that Congress handed us in the 21st Century Cures Act was, here's this information blocking thing, here's authorities to fine with real, real civil monetary penalties of up to $1 million per incident, 2 of the 3 actors, but in the 3rd actor, meaning providers, they essentially punted and said the Secretary of Health and Human Services will define what are appropriate disincentives, and has to do it within existing authorities and budget, and has to do it through notice and comment rulemaking. And it turns out that's actually a fairly tight box that you get put in once that happens. And so it took us, we started working on it really in the summer of 2021 because we were starting from scratch. There wasn't any work that had been done until then. So we're starting from scratch, and we started working across the department. And I'm really happy that, it took us 2.5 years or 2 years, but really happy that we finally got out this important piece of the puzzle, because it's an important part of, of the information blocking, provisions that the Congress put in statute, right? This isn't something that we're making up. This is the law of the land, and so, you have a duty to put all the enforcement into place. The challenge with it is that, we literally had a huge grid because it was wide open, right? They didn't define appropriate disincentives. They just said the Secretary will do that. And it's like, well, all right, so who's the Secretary? I mean, Secretary doesn't have a huge staff. So we worked with our agency partners to basically create a big grid, which was like every single agency, every type of authority that they have, and you can imagine how ugly this was, and then literally going through each one of those boxes and saying, well, what can we do within existing authorities? And there's a whole bunch of those that end up getting ruled out. It's like, well, yes, that program does allow civil monetary penalties, but only for what the Congress defined for those civil monetary penalties. So you can't just arbitrarily come in and say, oh, that now applies to information blocking as well, right? So that's kind of the, the block by block exercise that we had to do, and why it took over, 2 years. But really happy that now we're in a place that we've identified the first set and a framework. Importantly, an important part of that, and I think if you saw Secretary Becerra's statement on it, is the important part of this is it sets up a regulatory framework for the initial set of disincentives and future disincentives. So the idea is now we have a process for saying, all right, what else will we include as disincentives on an ongoing basis? Let me now just touch quickly. One thing, just for those who are following the statistics, we get roughly, I think it's like, probably 5 information blocking complaints a week still. It's on our website. These are all just screenshots from our website, so you can see it broken down every month. We update the data just to give as much awareness as we can of, the complaints that we're getting. Certainly not at HIPAA levels, which is in the tens of thousands per year, but, it is a pretty steady, like 5 per week. And still, the composition of it, I keep thinking this is going to change, but the composition of it is still mostly patients. Like 85% of the complaints are from patients complaining about providers, which is really interesting, right? Because we've already got HIPAA right of access, so there's some overlap there, obviously. But we're not seeing a whole lot of complaints so far in the other patterns that you might think, like vendors or provider to provider or any of those. Now again, it's very early. We might see sort of that this may not be a fully representative sample of what's going on out there, but just for your awareness, that's kind of what we're seeing in the data, and sort of pointed to the importance of getting the provider disincentives piece of this out there. It's like, well, if that's what the data is showing you, and patients are feeling strongly that that information blocking is affecting them, well, surely we need to fill in that enforcement gap to be able to address patients' concerns and patients' needs. And let me now just touch very briefly on AI. We call it in the rule predictive decision support interventions, and our approach on AI, and interestingly, we started on this 2 years ago. Again, in conversation with Secretary Becerra, we were looking at the issues of algorithmic bias, and there was growing literature on use of algorithms in clinical settings that had unintended consequences from a health equity perspective. And Ziad Obermeyer, a number of people have published a whole bunch of work, and that that work just continues. And so we started looking at that. The Secretary asked us then to start to look at what authorities do we have here? Like, are there things that we can do to help improve this situation? And then, of course, ChatGPT, sort of emerged or erupted last year, and our timing was in some ways perfect. We had already been thinking about this for 2 years, but then all of a sudden ChatGPT came out, and now if you look across the department, there's really there's very few specific regulatory levers over AI right now. There's FDA, which software is a medical device. They've approved over 700 devices now that are AI enabled, but that's fairly narrow, right? It has to be a medical device, and it has to be something that is going to be commercially marketed, right? Those are the two requirements in order for it to meet the requirement for FDA approval for safety and effectiveness. But if there's a whole bunch of other tools out there that we know don't meet those criteria, and if you look at AI, a lot of AI that's being developed now is actually by provider organizations. It's academic medical centers and others themselves who, of course, aren't commercially marketing it, even though it might be available in hundreds and hundreds of hospitals. But it's not going through any type of process like that. Our approach is not to go through, to have those be approved by ONC. We're not suggesting that we would do that. What we're focusing on is transparency. So what we're doing in our draft rule is saying that a certified technology developer has to make available information to providers, to their customers, about the AI-enabled tools that are in their EHR, whether it was developed by them or from someone else, but it's available in the EHR, and they have to create functionality for the representation of essentially 14 data elements, which you might think of as like the nutrition label or the model card for those who are familiar with with AI, that would at least give the clinical user some understanding of what is this algorithm. And as my friend John Halamka from Mayo Clinic likes to say, our algorithms are great. They were trained on 1 million blonde Lutherans in Rochester, Minnesota. And now here you are in San Juan, Puerto Rico, and you're asking the question, does this algorithm actually fit my patient population? And it might be a good thing to know, right? And so that's all we're saying, is we're just saying, make that information available. Where was it trained? Who paid for it? What steps did you use to think about health equity issues? Are there any known risks that have been identified in the use of this algorithm? What was the intent of the algorithm? Like if you're going to do essentially like an off-label use of the algorithm, that's okay. I mean, you can do that, but you at least ought to know what it was originally designed for before you make that decision. So these are the 14 data elements. They're called source attributes, but they're basically the idea of being a model card. We looked across the industry. There is no consensus yet on that, but we just thought, all right, well, here's a starting point. Right, here's a starting point. We'll grow over time, we'll all mature over time, but let's start here, and then we'll grow as an industry together with this kind of transparency. So that's kind of our approach to AI, as I said, really being incremental to try to say, let's just have some transparency so that clinical users can do what they do every single day. They're making decisions every day about formularies, about other things. Let's put this into that category so they have enough information to make appropriate judgments on their own. So I think I successfully used up all our time, which I didn't intend to do, but I'm happy to take a couple questions if there's time for that. No. There you go.
If we can get the mics working, we can go to 9:45.
Oh, we do? Oh,
Yeah,
okay.
and so we'll promise to be easy on you.
Okay. Okay. That's okay. You don't have to be easy on me.
Testing.
saw Stanley first. I don't. Hands? Wait, I saw this. I'll go in the back.
I'll talk loud.
You can yell, yeah.
I'm going to yell.
Okay, and I'll repeat the question.
We talked about this initially. Local initiative. How do we dovetail? Where is
Yep.
that connection?
Yep. Yeah, thanks for that, Denny. So we would love to talk to you, first off. I know there's a bunch of work going on in Utah, there's a bunch of work going on in California, there's always a bunch of work going on in Massachusetts, where I'm from. My message to all the local initiatives is it's fantastic that you've got this local energy and you're trying to do this stuff in a real way where you've got that circle of trust and you can move forward. But please, 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 leverage the hell out of the federal infrastructure that we're building here. Like those are public pipes essentially. And why would you recreate any of that locally? Don't waste your time on that. There's a ton of work going on to do that. So why don't you just assume that that's going to be in place? The ability to exchange information with each other using FHIR APIs, using basic IHE exchange for any of those organizations who qualify to be members of TEFCA. So making it a part of your local program, and we're talking to folks in California about this as well, is making as a part of your program a requirement that basically says, you need to join TEFCA in order to do what we're trying to do here, and then we'll build additional value-added use cases on top of that that may be local, but at least you can take off the table the basic exchange, being able to get information through a FHIR API, or being able to get US CDI information back and forth. Those TEFCA use cases for treatment, payment, healthcare operations, individual access, just being able to say, just leverage that, and then you can have your little corner of TEFCA to do additional things. One thing that's important and it's a little bit of a subtlety, but an important thing to call out is that in TEFCA, we have these standard operating procedures, which are the use cases that you see that we develop, and we publish it as a standard operating procedure. All that does is it defines something that everyone is required to support, and it standardizes it, so you don't have to go through out-of-band, pre-negotiation over, all right, well, I'm going to send you this, you send me that, all of that. It basically says, no, it's in the SOP. That means that if you're doing that SOP and you put that in, that's your purpose, that no one has to pre-negotiate anything anymore. But as long as what you want to do is under one of those exchange purposes, like as long as it's broadly under healthcare operations, for example, any participants are welcome to use the public health the public infrastructure, the TEFCA infrastructure here, to do additional things with each other, as long as both sides have the capability to do it. TEFCA does not prohibit that, and indeed, in many ways, just encourages it. To say, so in Massachusetts, for example, you've got a group of providers and payers. You can sort of say, all right, we're going to agree to the basic SOPs of TEFCA for treatment purposes and healthcare operations, whatever that is. But we have additional things that we want to be able to do that the entire industry hasn't agreed to, but here in Massachusetts, we've agreed to those additional things, additional data elements, additional technical specifications, whatever that is. As long as TEFCA supports it from a technical infrastructure perspective, and as long as it falls under one of those use cases like healthcare operations, you're welcome to basically have that side agreement that says, all of us are going to take our little corner of TEFCA here and do additional things. And that's what I would strongly encourage everyone to think about here. Again, just leverage the heck out of everything that we're trying to put out there for all of you to be able to, to leverage.
All right, I hope this is on. I want to commend the ONC. There's been a lot of work done, and it's incredible to see. However, I think one of the things that gets missed is that there are still healthcare services and providers who fall outside of the mandate and the regulatory environment who are being left behind. Specifically, I always talk about dental. I'm sure everybody in the room is ready for me to stop talking about dental. But we have been operating really as a sort of, if you build it, they will come environment, but the market is just not responding in that way. What role does the ONC have in making sure that we're not leaving these providers out of the loop because the rest of the market's not meeting them where they're at?
Yeah, it's a great question. One of the challenges that I think people don't fully appreciate is that, with our authorities, you always have to live within your authorities. So ONC authority as it relates to certification of health IT is actually voluntary. It's not a requirement. And people think it's a requirement because, again, 97% of hospitals and 80% of providers, ambulatory providers, are using certified electronic health records. But it's not because we have authority to tell Epic, you must certify. It's because CMS, in their payment rules, tells the provider, you are required to use a certified system. And then they essentially are telling Epic, your system needs to be certified, otherwise I can't buy your system. So we don't yet have that kind of business triangulation with dental. Happy to talk to you offline, and we're working with CMS who've been thinking about dental, and they've stood up a little bit of capability there. But I think that's what we need to figure out is what's that other piece of the puzzle that will allow us to be able to do more affirmative reach out to those vendors to say, hey, you really do need to get certified, even though it's voluntary, to support your practices.
Morning. I was fascinated by your websites on testing and status and such. On the HIPAA side, the regulatory side, we have a difficult time in the industry keeping track of the status of entities that are implementing when they change standards or even providing test data. How is it that you were so successful in getting those websites, yet CMS doesn't provide that, even though they have the regulatory authority to enforce?
Yeah, I mean, I think in part it's the beauty of, I don't mean this in a pejorative way, but the beauty of the modern internet, right? FHIR APIs, RESTful APIs, and the requirement that those be publicly accessible. So those two things put together allow us to just build modern tools that say, I can go out and just ping APIs once I know that endpoint, because per regulation, they're required to be publicly accessible, and they're RESTful APIs, and we kind of know how to do that. Whereas a lot of the transactions you're talking about are like in networks, right? And so you can't actually ping them because it's a network. So it's only if you're a participant in the network that you're allowed to do that.
Thanks.
Dr. Tripathi, we have a question from the virtual group. Will there be a certification program around USCDI plus data sets?
Yeah, so the way we're thinking about that is that the USCDI Plus initiatives are, sort of accelerators. So each of them is an accelerator in a particular domain, and some of that may lead to acceleration of maturity of certain data elements that would sort of qualify for being in the USCDI, and that would mean that you could incorporate those in the USCDI to say, that all right, that seems like it's generally applicable, and through that work of the USCDI Plus initiative, it's actually accelerated the maturity of it, so it's now ready for that. But I think, our idea is that we'll go through a litmus test kind of process to say, is it, A, is it mature enough, but B, is it generally applicable? Because we don't want to just be dumping all of those into the USCDI, because again, the USCDI plays this critical role of being a minimum data set. And you don't want to be putting all these advanced cancer data elements, for example, for USCDI Plus for cancer, into everyone's certified EHR, because not everyone needs those data elements, and it's a burden on everyone. And it creates bigger and heavier systems that people don't want. So I think that's the balance that we're going to try to strike, is to be able to, in sort of a tactical manner, domain by domain, sort of figure out, all right, which ones sort of get to that maturity level, and then we'll try to figure out that voluntary certification program that we call the SVAP that we might be able to creatively use there. So for example, you're able to say there's voluntary certification for a set of data elements that are now in the USCDI Plus for cancer, let's say, and you are a vendor that serves oncologists. Well, the oncologists who are participating in a particular program, like the CMMI EOM program, for example, focused on oncology, there could, I'm just speculating, right? There could be a future requirement that says, oh, you're required to use a certified EHR, and you're required to have the voluntary certification related to cancer data elements in order for you to participate in this program, because we need those. So that's kind of how we're thinking about it. I think we want to see how that matures and how it evolves before we specifically say, here's exactly how it's going to work.
One more. I can close with this one. This is a nice one from Ferris Taylor online. You have an ability to keep on top of all the innovation and technology impacting healthcare. What advice do you have on how you keep current with everything and how you anticipate where healthcare will be or needs to be in the next few years?
Wow. I like to think I have track of everything, but there's a lot more going on that we don't. I mean, we've got a fantastic team. and 180 people at ONC who have deep, deep, deep experience and expertise. And I'm always amazed when some like weird issue comes up that I think is weird, came up in some meeting. I'll bring it back, and it's like, oh, we worked on that 3 years ago. Here's the briefing paper that we did. It went nowhere, but and then here is the person who's deep down in the bowels of ONC who is actually an expert on that, on that particular issue. So, I don't have a great answer for it. I mean, I think a part of this job gives you visibility that almost you're forced to have because it comes to you. You don't have to go out and actively seek a whole bunch of it necessarily. So in a way, I think anyone in this role is going to have more visibility than you would otherwise have because it's sort of reactive in a way because it comes to you. I just can't understate the importance of having a really good team.
Mickey, watch out. Here's Rob Tennant.
Okay. Yep.
Yeah. First, let me thank you for being here and for ONC's ongoing collaboration with WEDI.
Thanks, Rob.
There's a lot of interest in the fire prior authorization rule. It's now gone to OMB for final disposition. I want to go back to January 2022 when ONC put out its RFI because providers need the technology in order to take advantage of this. Payers are going to be required to do this. What's the status of including these requirements in certification, and I would argue ahead of the compliance date, so providers have the technology in place, be able to test, and then go live with the payers?
Yeah, no, it's a really good question, so thanks. So we are, any other questions? No, sorry. We're working really hard with CMS on, you've got these two things going on, sort of in parallel. And as I described before, because ONC certification is voluntary, we always want to make sure that, well, we need to have a program that actually has a programmatic hook. Otherwise, we're just certifying things out in the wild, and that's a waste of everyone's time. Right? I mean, if you're just certifying something, no one's going to come and certify their systems. So we're looking, in HTI 2, we are looking very hard at prior auth. I think we've, sort of said that in a number of places. So we are looking very hard at that and, looking at a lot of the feedback that we got in the RFI, which was pretty overwhelmingly encouraging to say we need to do something in this area, especially with CMS having both policy requirements as well as requirements related to what payers would be required to support you. Obviously, that's not going to work if you don't have something that's scalable on the provider side as well, right? So we recognize that. I mean, there's a lot of, sort of complexities in there, but we're looking really hard at that because, it's a really important industry issue. And that's as far as I can say about future rulemaking, but hopefully you kind of get the message that we're looking really hard at that. And we see the importance. The timing is always really hard because, we work really hard with CMS. We're kind of just embedded with each other, on a daily basis. But, one of the wild cards that always comes in is, well, you just said it, right? CMS has got their interoperability rule with OMB, and then, we'll put our rule, go through that process, and then it's an OMB, and then those come out at different times. And obviously we're all on the same team, but OMB has all, they're working with every agency, so sometimes that timing doesn't, perfectly work out. And so, as an industry, then we may just sort of say, well, we got this transition period. It didn't work out the way we wanted to, but at least they're both out there, and at some point they'll join, and then we can, sort of move it forward. I would point out, since you mentioned APIs, though, another really important part of HTI 2 that we're looking at, and I think we've publicly said this too, is looking at how certification can benefit other areas of healthcare writ large. And so public health, for example. We're working with the public health community, CDC, and jurisdictions on thinking about what might certification of public health IT systems look like. Because, if you think about it, one of the big challenges that we have, and EHR vendors say this to us all the time, that you certified the pitchers but not the catchers. So if you're like a Cerner, or if you're an HCA, you're across the country, ONC and CMS tell you you need to do your public health reporting according to this standard, but then you have 64 primary jurisdictions, each of whom has their own variation, and they're like, well, I have to do it 64 different ways because that's the only way they'll receive it. And so now we're working with the CDC and with jurisdictions to say, well, wait a minute, maybe we should be certifying those systems on that side as well to receive what the pitchers or what the HR vendors and the providers are required to send. And that'll allow a lot of scalability and since 86% of the dollars that are used by jurisdictions for public health actually come from the federal government, it's not any different than the way we approach it from the provider side, which is you're receiving dollars from Medicare and Medicaid, then you have to follow certain rules. same concept could apply for, for other areas as well. So that's another area that we're actively looking at, which I think is, a really important area for us as a country.
Micky, thank you so much for the hard work your organization is doing. And
Thank you.
Thank you for the presentation.
Great, thanks.